around me waiting for waiting for their coffee, but I think I'll be fine. So it's great to be with you all today and a real honor to talk about this topic. So I just want to speak a little bit to what brought me to this work. As Rachel shared, I've been a clinician for 22 years as a practicing full scope midwife at a hospital outside of Seattle. And in this role, early, maybe like I don't remember, 5 or 10 years into clinical practice, I remember uh, someone coming to me saying, that patient that you saw today, you didn't make her feel very good. She came to us and she said she didn't like how you talked to her about her weight. And she felt kind of shamed in that conversation. And I was absolutely just really bothered and was embarrassed. And it was really hard for me to hear that I had harmed a patient. And I thought, what did I say? I really don't even remember what I said to the patient. I just remember maybe talking to her about normal weight gain in pregnancy and maybe perhaps where she was in that progression. And so that was like a little bit of an eye opener for me. And then separately, I was in my practice, I've always was served as sort of as the data person, collecting our stats on who, risk factors that patients had and what their birth outcomes were. And I had noticed a trend that of our patients that birthed via cesarean, um, a lot of them had elevated BMI listed as one of their antepartum risk factors. And I just sort of wondered, why is that? Is there a correlation? And these were not patients that were being induced. These were not patients that had gestational diabetes or gestational hypertension, just spontaneous labor and receiving care from our practice of 8 midwives. And so I was also sort of curious about that. And the combination of the two is what led me to pursue my PhD in nursing science in Vanderbilt. And I was really interested in understanding the concept of weight bias and what it was, and if there's anything I could learn more about it and perhaps make a difference in mitigating weight bias among healthcare professionals, which is really what I'm going to be talking about today. So these are our objectives. I really want to start with just level setting and just defining what weight bias is, talk about different terms that might be used for weight bias. I want to talk about the harms of a weight loss centric approach, which is really how most of us have been trained as healthcare professionals to talk about weight loss and thinking about what that means in terms of our speaking with patients. I want to talk about maybe a new framework that you haven't heard of called Health at Every Size. And I want to talk about some strategies that you could implement feasibly in your healthcare setting immediately that might help make a difference in your patient care. I want to speak to a little bit of just the history of this work. I very much see myself as a guest in this work. Sabrina Strings is the author of this book called Fearing the Black Body. She's a sociologist. And if this is a topic that you're like, I really want to read more about this, I strongly recommend this book. I want to just say that this movement really was started by the African American population, experiences of harm and living in the Black body. And for me, I identify as a white woman, and I wanted to say I very much am a guest in this work. Talking about weight is very sensitive. It's a topic that requires a lot of thought in our language and how we approach it and when we talk about it. And even talking with you today, I'm sure I'll fumble my words as I talk about weight bias a little bit. I'm very much learning and trying to just do better at this. So I just ask for your partnership as well as we work together and talk through this. So speaking of language, I just want to start there. Many of us are very comfortable using, ICD-10 definition, obesity, the word, what does the word describing the patient perhaps as obese. But I really want you to, if you could, rethink use of that word, because the word obesity actually means to eat oneself fat. That's what the word means. And many studies have been done asking patients who live in larger bodies, what are words that you would prefer healthcare providers to use when talking about your body habitus or about your size? And there was a lot of different opinions from patients about what words they preferred. Some of them said, higher weight. Some people preferred the word fat. But the number one word that patients said they really do not want healthcare providers to use is the word obese. It was very it felt discriminatory to patients. And so I would encourage you to think about shifting your language away from using that word. In my PhD research, I used higher body weight. I'm going to talk today a little bit about using elevated BMI and the limitations of the use of the BMI. Another set of phrase that I have talked to patients that I feel comfortable using is living in a larger body, because many patients that we are talking to that do live in a larger body, this has been their experience their whole life, really since childhood. So I just want to, I guess, encourage you to think about the language that you use. And again, just a little asterisk of avoiding the word obese or obesity. So what is weight bias? I would say in US culture, it is very much the last socially acceptable form of discrimination. If you look at different types of implicit and explicit bias of all types in our country since the murder of George Floyd, really a lot of forms of discrimination have decreased tremendously, but weight bias has remained absolutely stagnant. In the US culture, we feel very comfortable talking to people saying, have you thought about going on a diet? Have you thought about exercising? We think we're doing someone a favor by making suggestions. And the shaming is quite prevalent. I'll share with Rachel some resources after this presentation, but there's a YouTube clip of James Corden, a late night talk show host. It's about an 8-minute clip, and he talks about his experience of living in a larger body. He had been shamed by another talk show host, Bill Maher, and he basically talked about, this has been my life, and I don't need anyone to give me advice about on what to do. And so I think I want to just point out that it's very much part of our culture that we feel comfortable talking about, someone's weight and perhaps using some words that might feel shaming to someone. So the definition is, I want to make sure you understand the definition of what that is. Could be both implicit and explicit. Implicit is really unconscious feelings of, I'm not really sure I want to pick that person to be on my team, or I'm not sure that I want to sit next to that person on the bus. It's very implicit. You're making sort of unconscious judgments in your mind. Explicit is sort of what I just described with James Corden's experience of being openly shamed. So weight bias and weight stigma are the same thing. Some people use them differently, but they're essentially interchangeable. And another term you might see is the use fat phobia, which is, I've really in my research tried to move away from that term. If we think about phobia as being associated as an illness, something that needs treatment, but really fat phobia is just another form of discrimination. So what are the health outcomes of someone who experiences weight bias in all parts of their life, not specifically from their healthcare provider, but in their everyday life? The research is extremely profound. That speaks to the harm that can be caused to someone. That weight bias can lead to feelings of depression or anxiety, low self-esteem, social isolation. Believe it or not, it actually can lead to weight gain. If you think about the pathophysiology, we have microaggressions or macroaggressions that are
Dr.
occurring.
Bradford, I'm sorry. I
Yes,
just want to tell you, when you're in one area, I'm not seeing you. You're very clear, but then it kind of like fades out. So maybe if you just speak as close to, I guess, the microphone or computer as possible. Thanks.
sure, sure. If I stay right here, how is that?
Uh, okay.
Is it better?
Now it's better. Yes. Thanks.
Okay, great. I'm so sorry.
That's okay.
Okay, great. I appreciate your patience. I was saying to Dr. Campbell, you all know about weather out there, so can understand the challenges. Anyway, so just speaking to the health outcomes from weight bias, the picture here is just speaking to how micro or macroaggressions can lead to stress, inflammatory processes, increased cortisol, which can contribute to weight gain. And I think the outcomes that I think are most disturbing for me is increased mortality risk, and suicidality and substance use. So mortality risk, you think, oh, well, you're living in a larger body, that's contributing to your mortality risk. But when you take that aside, um, unrelated to the health, perhaps any risk factors associated with living in a larger body, like diabetes, high blood pressure, setting all that aside, just the experiences of weight bias can lead to increased mortality risk. So very unsettling and concerning. So again, just calling your attention to that. I want to talk a little bit about BMI. So the body mass index was a term, it was created in the 1800s by a Belgian mathematician, believe it or not. And it was used, oh, can we go back to the last slide on BMI? It was designed to measure populations of people. And it was designed to measure populations of white men. And it was never designed to measure one person's individual health. But now it's very much used as a fifth vital sign in our day-to-day healthcare. We are looking at someone's BMI before we even greet the patient. And perhaps if there is some implicit weight bias there, we're already making some thoughts in our head of, oh, okay, well, this BMI is elevated and I need to think about this and talk about this. And so I want to just give pause to use of this term as a measure of someone's individual health. So I would ask, what do we think Serena Williams' BMI is, or LeBron James' BMI, right? So really thinking about BMI does not measure genetics. It does not measure muscle mass. It does not measure bone density. And of course, we still sometimes use it in pregnancy. It does not measure whether we are pregnant or not. And the other interesting thing about BMI is, we have our criteria. Institute of Medicine and CDC have divided BMI into certain categories, 20 to 25, 25 to 30, 30 to 35, and use terms of overweight and obesity. And then we have different classes of obesity. And interestingly, the guidelines switched from 27 to 25, so lowered the BMI level for categorizing the overweight group. So basically, more people became overweight when they reclassified that. And that was led, actually, that effort was led by a task force, which was funded by companies that make diet pills. So I do think that it's quite arbitrary to think about use of BMI and how we're using that in our everyday practice. It has been used to determine who gets health insurance, who needs to be induced when, who can access out of hospital birth setting. So it's used quite extensively for certain criteria, and I recognize that it should be used to a point, but I think it's really being overutilized in our healthcare practices for precluding certain folks from having access to practices that promote physiologic birth. We are making progress in recognizing the limited use of BMI. The CDC, AMA have come out and said, hey, this is maybe not the best marker of health. So we are making progress there. But as you all may know, BMI, oftentimes you can't finish signing off a chart unless you have made notation of adding the patient's weight, unless you've made notation of a diagnosis of perhaps of obesity based on that. So it's oftentimes our EMR system is flawed such that we can't really avoid getting away from calculating BMI from height and weight. This is probably a whole hour presentation in itself, but I just want to touch on this. So we all may be thinking, okay, we know that there are health benefits to someone who lives in a quote unquote normal size body. However, we also want to recognize that for many people, this is far out of their control. And there are many socioeconomic disparities that can be the root cause for someone living in a larger body. It's something called uterine imprinting, which I had never heard of before, but essentially for the fetus, based on the lived experience of the person who is pregnant, and their stress levels, their ability to have access to quote unquote nutritious foods, healthy foods, their access to be able to exercise, under nutrition of the pregnant person, or the pregnant person eating certain chemicals. All of those can influence that fetus's um, propensity to live in a larger body. So it starts very, very early prior to even birth. Obviously, then throughout a child's lifetime, what they are being exposed to in terms of chemicals in foods, um, ability to access, ways to move their body in safe neighborhoods. Then moving into breastfeeding versus formula fed. Um, Infants and toddlers who are breastfed have lower rates of living in a larger body than those who are formula fed. And of course, high glycemic index foods, calorie dense foods, highly processed foods. Night shift work. Many people in the room here can also relate to the stress of night shift, right? So more likely to live in a larger body for those that work night shift. So lots and lots of different reasons. I'm going to just talk a little bit now about um, how prevalent weight bias is in someone's life. It's really very prevalent in all aspects, from immediate family members. People are being shamed from their partners, from grandparents or friends. Childhood bullying for one's size is actually the number one form of discrimination. So at the age of 3, children have already associated living in a larger body as someone that is considered less than. For women, weight bias is number 2. Gender discrimination is number 1, but weight discrimination is number 2 for women. So we have higher expectations of women in terms of what their bodies should look like. This continues on through school. You think about being picked for teams as your coach, bullying from your coach or discrimination, and then thinking about being accepted to certain opportunities that present themselves. People who live in larger bodies are being discriminated. And these are all really, really tons of studies that have looked at this. Also in employment, being hired, being promoted. So it just continues throughout one's lifetime. Obviously, I don't need to talk about what's on the cover of magazines or, on websites, what's on our pictures on our walls of people when we show pictures of pregnant people, it's typically not of people that live in larger bodies who are pregnant. I'm going to focus now really the rest of my talk on weight bias within the healthcare setting. So in healthcare, there's been extensive research that has documented weight bias among all types of healthcare providers: nurses, physicians, nutritionists, diabetes educators, physicians that focus on bariatric care. It's quite prevalent. I had noticed that midwives had not been studied, which is what led to my PhD research. I was sort of curious. Well, maybe midwives, being the nurse midwives, being in the caring profession, the word midwife means with women. Maybe we'll have less prevalence of weight bias among midwives, and I'll spoiler alert. There's no difference. It's quite extensive weight bias among my profession as well. What happens? How does this translate in the healthcare setting? Well, research has said we spend less time with patients one-on-one in the exam room when someone lives in a larger body. We're less likely to develop a rapport with someone. Our clinical decision-making is impacted. Instead of someone coming in saying, I think I have a sinus infection, they might be leaving being told, you need to lose weight. We're just always focused on trying to give advice around losing weight, and not so much focused on what the care at hand needs to be. If you talk to pregnant or postpartum patients, many of them report experiencing weight bias during their pregnancy, birth, and postpartum experiences as high as 70%. And what does this translate to? So we unfortunately have higher rates of GYN cancer, breast cancer, and people who live in larger bodies because they don't want to come for care. They experienced harm coming in for a pap smear. Oh, I don't have the right equipment. Let me go get some different equipment in a different room. Well, that's, awful. So people just don't want to seek care. Higher rates of unplanned pregnancies. They don't want to come in for regular contraceptive conversations because, again, they're being shamed in the healthcare setting. So, all those reasons alone, those are, again, just in the GYN space, cancers and contraception. Um, I'm very interested in improving birth outcomes, which is really the future of my research where I hope to go. But I just want to share that with you. So, as I shared, I conducted a study among midwives. We're approximately 12,000 nurse midwives and across the country. I had about 17, 18% respond to my survey, 2,200 midwives. And as I shared in my spoiler alert, it was quite prevalent among midwives. Interestingly, I also was curious, is there higher or lower rates of weight loss among midwives who live in larger bodies? So if you are yourself live in a larger body, are you more or less likely to have weight loss? Or also in midwives who identify with different races or ethnicities. And essentially what I learned, you can go to the next slide, is these are my two aims. I won't get into that just for the sake of time. I've sort of summarized that already. Let's go to the next slide. And there's my sample, which I described. It's pretty extensive pretty prevalent across the United States. But let's go to the next one. You're all probably familiar with the Implicit Association Test, or the IAT. It's a free 8-minute survey that you can take if you're curious to see if you have weight bias. You go to Harvard Implicit, Project Implicit through the Harvard site. And this is what I learned, that 70% of midwives have some level of anti-fat bias, either slight, moderate, or strong. That was, I think, to me, most interesting in terms of, my findings. Explicit weight bias was also prevalent, but not as much as other healthcare providers. I will keep trying to talk loudly here. I felt like the music was getting kind of loud. Let's go to we can move on. I sort of, as I said, I hit the punchline. So I want to transition now. I have about 15 minutes left. I want to talk a little bit more about what can we do as healthcare providers to make a difference. And one of the 3 studies that I've published about weight bias summarizes these 9 points right here. So Rachel has that. I'll make sure that Rachel can share that publication with you all, which is basically strategies to mitigate weight bias among, not specifically in the pregnancy space, but really all healthcare providers, mental health care providers, anyone that's interacting with a patient in any point. So I think that I won't read these with you, but I really want you to think about comments that we're making, just different ways that we're focusing on the number on the scale. And I'm going to be presenting a different framework to think about this. Let's go to the next slide. What if we viewed weight as non-modifiable? You may think your eyes are blue, your skin is particular color, you are this is the body shape and size that you have. And if we really thought about this as a non-modifiable factor and really just focused on healthy behaviors and talking to patients about their behavior and not necessarily their weight, then I think that can make all the difference. Go on to the next slide. I'm going to touch a little bit about this. I want to mention weight cycling in the top right corner. Oftentimes, people who are intentionally losing weight, they're really focused on the number on the scale. Weight cycling is basically you lose weight and then you gain weight and you lose weight and you gain weight. We know that weight cycling is even more harmful to someone's health. So when someone does focus on just the numbers on the scale and not necessarily the behavior of, joyful movements, eating nutritious foods, eating to satiety, intuitive eating, that they're more likely to lead a healthy lifestyle versus avoiding specifically what those numbers are. I also want to just, as I said earlier, call out size diversity is normal. You think about animals, and just all different types of populations. We all come in different shapes and sizes, and really thinking about normalizing, um, uh, thinking about body diversity, different shapes and sizes. Let's go on to the next slide. I just want to make sure I have time to get through all my slides. So as you've probably gotten, sorry, the sun is coming in behind me here. As you've probably heard, shaming is really what my recommendation is to avoid. That it's generally just not healthy for someone to experience any of these terms or words listed here. We don't want to eat to restriction. We don't want to force exercise. Health at Every Size framework, which I'll be talking about, uses the term joyful movement. And so we think about moving our bodies with joy and how that really makes a difference versus someone who is a prescriptive, you need to do X amount of cardio exercise this many minutes per week. So really reframing that in a way that might bring someone joy. There are certain diagnoses that are associated with larger bodies. I want to just call this out that we don't necessarily want to assume that because you live in a larger body that you're at increased risk for A, B, and C. But these are what we have here on the screen are concerns that I think we just want to say definitely these are diagnoses associated with larger bodies. I talked a little bit about weight cycling already. So as I said, our recommendation is not for calorie restriction. It's not about looking at the number on the scale. It's really focused on specific behaviors. Go to that. So the principles of health at every size, or HAES. Those principles are listed here. I've kind of alluded a little bit already to number 3 and thinking about the language that we use, how we make someone feel when they come into our space, the pictures on the walls, and the images on our website, the equipment that we have available. So those are all parts of making someone feel comfortable in the healthcare space. Number 1, oh, can we go back? Sorry. Number 1, in terms of weight inclusivity, that's really just honoring all different size diversity. And then I talked a little bit about life enhancing movement or joyful movement and eating for well-being, thinking about foods that intuitive eating or eating nutritious foods. I also want to give pause to using the term healthy eating or eating healthy foods. It gives a little bit of a moral value. And we know that some of our patients may not have access to quote unquote healthy food. So really thinking about reframing that a little bit as well. I want to also be clear, and I'm not a HAES trained provider. I just really believe in this framework. I want to also be clear that we're not saying that all people are healthy, not saying that nutrition, exercise have no impact on health. And with a focus on healthy behaviors, yes, I do think that the numbers on the scale will change, but I think it's really a different approach instead of thinking about what the number on the scale says. So I just want to call out that it's not what HAES is not, because I think sometimes people misinterpret what we're talking about. So this is the study that I mentioned earlier that I will make sure that Rachel shares with you. Let's go on. And so I've talked, I think, about all of these principles. I wanted to slow down here just a little bit. At my practice where I am, we used to have the scale in the hallway, and patients were weighed in the hallway, and then it was reported by the medical assistant. I think it's important to think about, does that scale need to be in a central space? For some people, stepping on a scale is really hard because of being shamed their whole life. Could the scale be moved to an individual exam room? Could we have a small scale in every room? Or do we even need to take weight during the pregnancy? We're measuring fundal height, we're measuring fetal growth. Do we need to examine the weight? So I would just question policies around reporting a weight all the time. I want you to think about the magazines that are on your waiting room table and the pictures that are on your wall and on your website. And are you honoring size diversity and thinking about that? Do you have multiple size blood pressure cuffs in every room? Or is it the experience of, I need to step out and get a different blood pressure cuff for you. This one doesn't fit. Or I need to go get a different size gown for you. I need to get a larger size, right? So all the different ways that we can make someone feel like we have the care needed in their space to take care of them. I also think about consent. It's my last bullet here, but it really should be my top bullet. Talking about this is hard for many patients, and seeking consent to talk about it is number one. Oftentimes, I find I'll say to a patient, and this is again only when they come in for their annual, when it's an important time to be talking about healthy behaviors, not when they come in for a sinus infection, but they're coming in for their annual exam, and we're talking about healthy behaviors. Are you wearing a helmet when you're on your bike? Do you wear a seatbelt? Do you go to the dentist? And are you finding ways to move your body that bring you joy? And I ask, are you okay with talking about this? And many times patients will say, I want to talk about exercise. I don't want to talk about eating. And then the conversation ends there. I think it's really important to honor their wishes, again, because they're experiencing harm in our space. We really just want to have this be patient led. I think that's probably enough for that slide. So I just would encourage, again, probably another bulleted point that I want you to think about is really thinking about healthy behaviors, what your bodies can do and how they feel, and not how they appear or what they weigh. I think there's nothing more that you take from this talk today. I encourage you to think about that. And just really reframing. It's not about dieting. It's not about weight loss. It's really about being your healthiest self and ways that we can achieve that. I'll skip over the slide for the purposes of time. Let's maybe go to the next. There are some times that taking the weight is required. Obviously, epidurals, anesthesia dosing, severely underweight patients, so we need to be monitoring that much more closely. Pediatric growth charts. But I think you've kind of heard my points about questioning whether we really need to be recording weights in the prenatal care setting. Great. I definitely will be making my slides available. Let's see what our last slide is here. I think I'm pretty much at the end. And then we'll open it up for some questions. So one more slide there, Rachel. Yep, take home points. Perfect. So I think the majority of patients have experienced harm. It can lead to avoidance of care and adverse health outcomes. And I think we can do a better job of helping people feel more welcome in our space and asking permission to talk about this, using the language that they prefer to use, and not making any assumptions about their lifestyle. And so I'll just end on this quote from Maya Angelou on my next slide, and I will open it up for questions.